Are we ready?
I think let's go for it, Kasia.
Okay, all right. Good afternoon, everybody. My name is Kasia Cordas, and together with Professor Samina Raja, I co-direct the UB Community for Global Health Equity. I want to welcome you to the webinar today and to our series more broadly. As an intellectual community dedicated to the promotion of equity in education, practice, and research, the Community of Excellence in Global Health Equity is pleased to offer the co-production of knowledge for global health equity seminar series. In this monthly series, we examine a model of knowledge building that might be unfamiliar to some of you. Co-produced knowledge means different things to different people. By co-produced knowledge, the organizers mean knowledge that is developed under the auspices of cooperative, mutually respectful relationship between people whose practice springs from academia and those whose expertise arises from practice and or lived experience within a given community. Last month, we launched our series with an introduction to the co-production of knowledge and one partnership between an academic and a community activist who came together around issues related to housing. A recording of that talk is available on our YouTube channel, and we will put a link to it in the chat box. Before I introduce our speaker for today, I would like you to be aware of our chat box throughout the talk. You should feel free to use it to type in your comments or questions and to respond to one another. After Dr. Resnik finishes speaking, we will bring your questions to his attention. And of course, during the discussion, you will have an opportunity to ask questions and make comments directly. So now it is my pleasure to introduce our speaker for today. Dr. David Resnik is a bioethicist, and he will continue to explore issues surrounding co-production of knowledge. Specifically, he will give us concepts and examples to help us think through ethical issues that may come up when communities become deeply engaged in research. Dr. Resnik holds an MA and Ph.D. in philosophy from the University of North Carolina at Chapel Hill and a J.D. from Concord University School of Law. He was an associate and full professor of medical humanities at the Brody School of Medicine in East Carolina University, and also an associate director of the Bioethics Center at ECU and University Health Systems from 1998 to 2004. He was also an assistant and associate professor of philosophy at the University of Wyoming and director of the Center for the Advancement of Ethics at the University of Wyoming. He has published over 250 articles and 9 books on various topics in philosophy and bioethics, and is a fellow of the American Association for the Advancement of Science. He serves on several editorial boards and is associate editor for the journal Accountability in Research. Dr. Resnik was chair of the NIEHS, the National Institute of Environmental Health Sciences Institutional Review Board from 2008 to 2019 and is a certified IRB professional. Dr. Resnik, welcome, and thank you for joining us. You need to unmute. You need to unmute, we can't hear you.
Thank you for having me and for being a part of your very interesting and important seminar series. Next slide, please. There we go. There's my disclaimer at the bottom that I'm not representing the views of the NIEHS or NIH or US government. Next slide, please. So we're going to talk about community-based participatory research today. It's also called other things. It may be called community-based research or community research or something like that, but this is sort of what people call it now. This is research that is designed to develop knowledge or interventions that benefit a specified community and meet needs defined by the community. And so it could be any number of things. It could be a public health study. It could be an environmental research study. Could be a clinical trial, social science research. There's lots of different things that could be done here. And so what happens is that community members are substantially involved throughout the research process, beginning with things like research design. And then they may be especially important in development of consent documents and recruitment materials for the study. The community helps out with publicity, word of mouth publicity and making contacts for researchers. Recruitment, they are involved in that as well. And then when it comes time to, when the research project is done, the community may be involved in interpreting the results, what they mean for the community, what they mean for science more generally, and how the results could be applied to the community. And also they may be involved in decisions concerning publication of the results and exactly how that happens. Next slide, please. So trust, communication, mutual understanding and respect are especially important for this type of research methodology. This methodology was developed in the 90s in response to the realization that researchers were ignoring community needs and interests and harming communities in some cases. So what was happening in the early 1990s is that there was really an increasing awareness of how research had actually harmed or exploited communities. And there was a growing interest among ethicists and researchers and many others of developing new sorts of methodologies and ways of doing research that would not have these negative impacts on communities. But since then, it has evolved from avoiding negative impacts to actually promoting positive impacts of the research as well. And as I mentioned earlier, it's been used in lots of different research method types of disciplines. Next slide, please. Okay, so this is pretty expensive research to do. Generally, it's more expensive and logistically complex and time consuming than doing just regular sort of normal or not normal or the standard kind of research where you don't involve this community so much. So why do you want to go to all this trouble? Well, as I mentioned earlier, to try to prevent harm to community. And then the positive aspect is actually to benefit community. There's also something in it for the investigators. It can help them obtain community approval when needed. So really it's important for the community to have buy-in to a project to get the community support and recruitment and things like that. It can also build trust, which is important for current and future research. So one thing to keep in mind with community research is a lot of these communities have been and will be studied many times again. And actually, I've read some interesting ethics discussions lately about basically community burnout in communities that get overstudied because they're special communities or whatever, and people are really interested in them, and the importance of avoiding that. We actually had to face that problem too with a study I'll talk about later, the Gulf Project, the problem of studying the community too much. So as I mentioned earlier, this type of CBPR can enhance research design, consent, and recruitment by means of contextual knowledge and partnership. So basically, it can be good for the community and also good for science. Next slide, please. So here's some different ways that you can get community input for CBPR. First of all, you may should obviously involve local investigators. So you're not just coming in to excite and doing research, but you're working with people that are local, they know the community, they have contacts in the community, they can work with the community. You also will probably should have collaboration with community leaders, local government, churches, civic organizations, public health agencies, hospitals, and clinics. And these are different sources of, building the trust in the community. You could have community members on the research team as well, obviously as volunteers, but also as staff or even investigators on your study. So in the study that we did, we actually had a lot of community members that were hired onto the project to collect data. Another thing that was important with this is having a community advisory board. And the community advisory board, again, a lot of the same people that you're collaborating with, community leaders, local government, all those types of people could be on the community advisory board, as well as others. The community advisory board could review studies that are planned, could be informed about studies as they're ongoing. And when publication happens, the advisory board could be consulted about that. Another thing that is important for this is having a community IRB. It's felt that an IRB or institutional review board having it local is very important for having local knowledge and local perspectives on human subjects issues. So people that are within the community, they understand the values of the community, traditions, concerns, things about the community. I will point out, and maybe we can discuss this later, that the mandate that the new common rule has now for human subjects research of a single IRB seems to be at odds with this idea of local IRB review, because what it requires is if you have a multi-site study, there has to be a single IRB. And if, say, one of the research sites is some big university somewhere, it may be that the local IRB sort of gets cut out of the picture. They're not really reviewing as an IRB. So there's questions about, well, how are you going to get that local input if you don't have a local IRB? And there may be hopefully ways to work around that. Next slide, please. So to do this right, you have to have partnerships and alliances that are established before the research begins, right? So you don't want to have it like, by the way, we're doing this study, by the way, and we want your help. It has to be already that the community is on board with your study before it begins. But of course, building alliances and partnerships, again, can take a lot of time, a lot of groundwork, a lot of, just sort of local effort to try to do this. So there should be meaningful review prior to the IRB submission. Then the engagement with the community should be ongoing. As I mentioned, if you have a community advisory board, the advisory board can be updated about what's going on with the study. Another way of doing this that I've seen studies do is they put out a newsletter and they have other materials on their websites to keep community members informed about what's going on with the study. And the research project may evolve in response to community concerns then. So suppose you have a large epidemiological study in a community, and then as the research is done, some community members say, well, there's also this other health problem that we're concerned about that was not originally, you were not originally planned to study. Well, you could modify the protocol at that point to include, studying that particular problem. One thing that people have recommended, and I don't know how often this is done, is drafting agreements with community advisory boards that establish clear expectations for investigators and the community members in terms of, what's going to happen in terms of the protocol, in terms of publication, communication, and so forth. Next slide, please. So one of the conceptual issues with this kind of research is, what is the community? It is actually a pretty hard thing to define when you think about it. In general, you could think of a community as some group of people with common characteristics that are maybe united by something, but it could be any number of things. So we typically think of it as geography. So, maybe your community is, say, some people living on a Native American reservation in Arizona. That's the community. Or maybe it's, some small town in the Appalachian Mountains or something. That's your community. But it could also be united by other things, people living in a particular township or under some particular government. It could be race or ethnicity. So maybe you're interested in studying people of a particular race, some particular health concern or something else with that race. And so the community then could be wherever that race is. So a good example of this is the Ashkenazi Jews have been studied many different times, and we've actually learned a lot about the genetic basis of breast cancer, other types of cancer and other sorts of diseases. Cystic fibrosis, I think, is one of them, Tay-Sachs, in this population. But the Ashkenazi Jews are, an ethnicity, but they're still considered a community in this sense, even though, they're living in lots of different places. The community could also be united by language, religion, ideology, perhaps even disease status. We have a study at the NIEHS that's looking at breast cancer, and it's called the Sister Study. It's looking at sisters with breast cancer. So you have one sister that has breast cancer, and then they recruit the unaffected sister, and they follow these two people to try to tease out genetic and environmental factors in breast cancer. But you could consider those people to be a community in this sense, is that their breast cancer is what is uniting them. Next slide, please. So I think it's pretty important, if you're going to be working with a community, that the community have some kind of cohesive social structure and legitimate form of representation, so that the community needs, concerns, or values are communicated to the investigators. US citizens obviously is not a cohesive community, as we know from the politics going on, but even way before that. Residents of where I live in Apex, North Carolina might be a cohesive community. Maybe it would be more cohesive in some smaller, more local community. Native Americans, again, is probably not a cohesive community, given that there's so many different Native Americans living all over the place, and they have so many different interests and concerns, and there's no real governance structure. But the Havasupal Native American Tribe might be considered a cohesive community. Next slide, please. Okay, so this is an interesting slide that I actually didn't put together myself. So this is coming, Cassia, who puts this together? You and, okay. Anyway, we talked about this a little bit. So if you think of this as kind of a scale or something like this, at one end, at the left side of this scale, you have traditional investigator-initiated and led research. So like so many kinds of studies we're familiar with. And then on the right-hand side, you have completely co-produced research and knowledge, co-produced by, I guess, the investigators and the participants or the human subjects being studied. And then somewhere in the middle, it's more maybe closer to co-produced knowledge is what we will call community-based participatory research. And then, you know, on the left-hand side is just investigator-led research with an advisory board or just some kind of community input, which, you know, more and more is basically the minimum you have to do now when you do this, involve a community in some way. Next slide, please. So here's an interesting contrast then between what I would call traditional research and CBPR. So in traditional research, there is supposed to be a clear division between investigator and research subject. That's kind of what makes the research objective, right? You're studying something, a research subject. And a lot of the methodology is actually designed to maintain that division. In CBPR, the line between investigator and subject is blurred somewhat because you have subjects who may have actually participated in the research design or in developing the research aims or objectives. In traditional research, the aims and objectives are established by the investigator, but in CBPR, the investigators and the community work to establish the aims and objectives. Again, in traditional research, it's designed by the investigator, but in CBPR, there is community input into research design. I would say, however, that what I've seen so far is that community input into research design tends to be somewhat limited. I mean, for example, I mentioned helping researchers design survey instruments and consent documents and things like that, where more lay knowledge is useful. I haven't seen community input that actually would go into some details of scientific methodology like statistical design or clinical trial design or something like that. That does tend to seem to be more specialized in terms of that knowledge. In traditional research, data is collected by members of the research team. And in this new CBPR, it may be collected by members of the team, which could include community members. In traditional research, publication, dissemination decisions are made by the investigator. In CBPR, the community has input into data interpretation. Excuse me. In traditional research, the investigator and the institution have ownership of intellectual property. That might include things like obviously patents and copyrights, and I might throw in there biological samples, which are a really important piece of property in research, and has been a lot of contention over that. I can't really see the slide fully on this, but I think what I'm saying basically down there is that you have community ownership of intellectual property as well. Next slide, please. So ethical issues can arise in this kind of research because the scientific and community interests may diverge. Investigators are primarily interested in knowledge advancement. They may be interested in advancing their own careers, obviously, which goes with knowledge advancement. And part of that is publication and sharing of data and results. That's all important for science, all that. But communities are primarily interested in the benefits for the community itself and for individuals within the community. That's really what their focus is on. It's not that they're opposed to publication, but that's not their first concern generally when you're involved in this kind of research. Next slide, please. So some examples of potential disagreements. So researchers want to do a study on antiretroviral drugs for HIV, but community members would like them to study traditional herbal methods for prevention. So I've actually heard of examples like this in Africa, where people have been doing HIV research, and communities are, why can't we also be studying our traditional herbal methods of, of preventing HIV? In research design, community members would like investigators to do an uncontrolled trial of a treatment for Ebola to give people more access to the treatment. And this has been an issue, was a big issue in the Ebola research, where, because of the emergency situation, community members wanting to make, more of this, any kind of treatment available. And we've had the same sort of pressure with COVID-19, obviously, but then for the sake of the science and for the sake of, good regulation of drugs and things like that, you want to do a clinical trial, not just uncontrolled studies where a lot of people are let in. In data interpretation, community members may disagree with the interpretation of the data that proposes, for example, race or ethnicity is a key factor in mortality related to a type of cancer. So what may happen, is that the community may be concerned about stigma, bias, or something else that comes out of a study that makes the community look bad. And so they might oppose whatever interpretation. In terms of publication and dissemination, community members may oppose widespread sharing of biological samples, and again, publication of embarrassing results. Now, one way of handling the publication of embarrassing results, which sometimes works, I think, is to not mention the name of the community. Like you say, oh, we were studying a town of 5,000 people in the North Carolina mountains, or something like that. But the trouble with that often is that if you say enough specific about the community, people will be able to identify it. And if you don't say enough specific about it, you don't give in other researchers the kind of knowledge they need from your study. Like, for instance, it might be very important to say that the community was near some kind of power plant. That might be an important health factor, or it was near a river. But once you put that knowledge, once you say that, you're identifying the community. So it's pretty hard to de-identify communities these days. Next slide, please. Okay, so before I get to a good study, what I consider to be a fairly successful study, I will just put in this cautionary tale. So this has to do with the investigators from Arizona State University that were studying the Havasupal American Indian Tribe. They actually live in some really beautiful land near the Grand Canyon in Arizona. And they collected 200 blood samples from members of the tribe. The consent form stated that the samples and data would be used for research on behavioral and mental illnesses. But prior to the initiation of the study, investigators told tribal leaders they would focus on the genetics of this diabetes. So right here, there's sort of a lack of attention to communicating with the community board, right? If you think of these tribal leaders as like the community board, there was some misunderstanding that happened here, even if the consent form had the proper information in it. So members of the tribe later learned that the investigators had used the samples and data to study diseases other than diabetes and shared the samples with other researchers. So they strongly objected that the data were used to study schizophrenia, inbreeding in the tribe, and the tribe's evolutionary and genetic origins, and they filed a $50 million lawsuit. They alleged in a lawsuit that the use of samples and data violated the informed consent by the participants. And then the university later settled with the tribe out of court. It returned the samples and paid $700,000, which was divided among 41 participants. So one of the things, one of the really bad things that happened with this study was there was a lot of distrust that's come from this. I've read quotes from people that were interviewed about this in the community, and they said, I'll never participate in a study with this university again, right? So because of this, they've kind of spoiled things for other researchers and also probably for the community itself insofar as it can benefit from the research. Next slide, please. Okay, so here's some lessons. There's lack of effective consultation, lack of understanding the community's needs and concerns, misunderstandings and miscommunications. So hopefully CBPR can avoid these types of problems. Next slide, please. So I'm going to talk about the Gulf study now and some of the things that that happened with this study. So as you probably know, in April 2010, there was an explosion of the Deepwater Horizon oil spill operated by BP. It killed 11 people. The damaged oil well released 5 million barrels of oil into the Gulf of Mexico. This is one of the largest oil spills the world's ever seen. The well was not capped until July 15th, 2010. Now, it wasn't that long ago, but I know that today the news is dominated by politics and COVID-19, but I remember 2010 pretty well. And it was like almost every day that went by, like, when is that well going to be capped? When is that well going to be capped? Everybody was really on top of it. And we were concerned about the environmental damage that was just happening in the Gulf of Mexico from this, this oil spill. So there were also chemical dispersants that were used to remediate this oil spill. So you've got all this in the environment, not only the oil, but also the chemical dispersants. And 150,000 people, mostly from Louisiana, Mississippi, Alabama, and Florida, participated in the cleanup effort. So these included contractors hired by BP and workers from state and federal agencies. Next slide, please. So most of the state and federal response to the oil spill involved cleanup and restoration, but some involved research. And this is what the Gulf long-term follow-up study was about. So the planning began in 2010. And there was all kinds of review. It went through NIH scientific review committees. The Institute of Medicine looked at it. The IRB looked at it several times, and we actually had some emergency meetings during Christmas to try to get this thing approved quickly. I was the chair at the time. And there was also a local community advisory board that was set up pretty early on in the process. I think the advisory board had certainly looked at the protocol and everything long before it got to the IRB. I think certainly was looking at it in the summer of 2010. But the study was not launched until March 2011, which is actually, pretty quick in terms of some studies, but not quick enough really in terms of this study, because of you really, for an environmental study like this, you really need to get into the field as soon as possible because of the exposures fade. Most of the chemicals are gone from people's bodies pretty quickly, within 30 days or something. Memories fade. There's, for interviews and things like that. So there's a lot of reasons to get into the field as soon as you can. So the study was completed in 2013. The main goal was to learn more about how the oil spill and the cleanup efforts affect human health. And so this could be useful in protecting people from harmful effects of oil spills. So theoretically, knowledge from this study could be used for planning cleanup efforts in the future to better protect human health in the future. Next slide, please. So it was an observational and long-term study. study. It's supposed to go 10 years. I think it's probably still going. The study recruited about 33,000 workers who were involved in the cleanup. And it was designed to determine whether these cleanup efforts had any adverse health impacts. Some of the data collected included blood, urine, hair and toenail samples, pulmonary function testing, and clinical exams. And the data were collected in local clinics as well as during home visits. Next slide, please. Let me just back up for a second. I will mention that for the data collection, again, these were local, mostly local people. So the study used a contract research organization that hired local people to do these home visits. Next slide, please. So it's really important to understand the participant characteristics in doing a study like this. Low socioeconomic status, high rates of poverty and unemployment in the Gulf states, some of the worst poverty in the United States. Most of the participants that were in the study were transient and frequently locating. So, a lot of these contract workers, they just go from place to place, and they, may be hard to contact them. It was ethnically, culturally, and linguistically a very diverse group. So you had languages English, Creole, Spanish, and Vietnamese. And actually, part of the local advisory board included representatives from these different sort of language groups that were there. They were already suffering from stress, depression, and trauma from the oil spill, as well as previous disasters such as Hurricane Katrina, which hadn't been that long ago before this thing happened. And they were suspicious of government due to disappointments from past responses to disasters. Next slide, please. Now, let me back it up a little bit. I think because of their suspicion, partly they were like thinking, a lot of them, at least is the word I got from the investigators, is, well, what are you going to do for us? Yeah, you're going to come in and study us, big deal. What are you going to do for us? Next slide, please. So here's some of the community involvement. It included meetings with representatives of state and local health departments, work advocacy and occupational groups, businesses, universities, cultural and religious organizations. There was a community advisory board. There was a local IRB at LSU. And as I mentioned, individuals from the communities were involved in data collection, recruitment, and translation services. Next slide, please. Okay, so first issue is the issue really of benefits. Many of the participants lacked access to health care and were angry with BP and frustrated with what they perceived as a lack of government response to the oil spill. So some community activists urged researchers to provide health care rather than, or in addition to, health research. So this is outside of NIH's mission as a research organization. So we realized that, we really couldn't provide health care. So what could we do? Next slide, please. So what they tried to do is provide them with some kind of a health benefit. So these included the health information they got from clinical tests, physical exams, and mental health questionnaires. So this was really, there was a lot of extensive planning for this, and planning in terms of feedback, of giving people information about their results and things like that. And speaking from someone who has been a human subject in a few studies, I can tell you that this is not an insignificant benefit. We don't really, in the IRB world, we don't call this a direct medical benefit, but it's really useful, for example, if you're getting tested to know what your cholesterol level is, or some other blood tests, or to have a physical exam and somebody, checks out different parts of your body. That can be really useful health information. It's like getting a free checkup. And as I mentioned earlier, these are not the kind of people that were, had the healthcare resources to get checkups very often and get information about themselves, their health very often. So this, I think, was a significant benefit. Another thing that they got the investigators drew up a very large list of physicians and mental health professionals for referrals from the health information they got, like if they found out that they had high blood sugar or something else. They also paid money, which in the IRB world is not considered a benefit, but in the real world, money is a benefit. And this included $150 for participating, and then they could be entered in a drawing for another $500. This was actually added later to try to boost recruitment for a follow-up study. Next slide, please. So here's what the informed consent document said. Benefits to subjects. You may help your community and others by helping researchers learn what to expect after an oil spill. You may take pride in being part of a study that will help answer questions about the potential health effects of the Gulf oil spill. You may also benefit from getting the results of screening tests from referrals for healthcare. However, you will not receive medical care or other direct benefits from being in the study. So I think that was pretty clear. It tried to put a positive spin on it, I think. It's interesting, if you look at informed consent documents, when there's no benefit to the research subject, what they usually say is something like this: you may not benefit from this research, period. And then they tell you some good things that may come of it. But actually, this doesn't tell you until the end that you may not really, directly benefit. Next slide, please. So confidentiality was another issue in this study. The oil spill generated a great deal of litigation against BP, which meant that BP might try to access study data. So how would this happen? Well, BP might try to access study data from participants who are suing BP to use it against them in a lawsuit. So for instance, if you were suing BP about some health problem that you had that you said was caused by the oil spill, they could try to get your medical records and prove that you already had the health problem prior to the oil spill, so BP didn't cause it. There was fear, therefore, that BP might try to access study records, and that could negatively impact study recruitment. Next slide, please. So to deal with this confidentiality, this issue, the investigators got a Certificate of Confidentiality to protect the data. It allows investigators to refuse to share data requested in litigation. It's not perfectly good. It's not perfect. There are some issues with it we can discuss later, but that's what it's supposed to do. Next slide, please. Another interesting confidentiality issue I'd never really encountered before as an IRB member was that this report, there's reporting of suspected child, elder, or spousal abuse or threats of harm to self or others discovered during telephone calls or home visits. So this was identified actually during the meetings with community and local health agencies from research on prior disasters where mental health issues were paramount. So study staff members were trained on how to handle these situations that might require reporting to the IRB, social services, the police, or other authorities. And participants were told during the informed consent process that study staff might make these reports. So these things could happen because if you go into somebody's home to do research, you can see things. You can see a child is being abused, or a spouse. You can see evidence of spouse or child abuse, or any number of things. And you may have to report that under, local laws. Interestingly, there were a couple, now during the phone calls, there were some people that had suicidal ideation on the phone calls when they were doing this. And there was also someone that threatened to blow up BP's headquarters. So, these were real things that I was privy to when they were happening. And I was informed as the IRB chair that this stuff had been going on, when it was going on. But fortunately, the investigators had pretty well worked this out, how to handle a situation like this. Next slide, please. There was a conflict of interest in this study too. So funding was largely provided by the NIH, but BP was also giving some money to this study. It was from a $10 million gift that BP had given for research in states impacted by the oil spill. So the NIH leadership allocated $6 million of these funds to the Gulf oil study. And to avoid any real or apparent conflict of interest, steps were taken to ensure that BP had no involvement in designing or implementing the study, or analyzing the data, or interpreting or disseminating the results. BP's only involvement was disclosed, should say BP's, the extent of its involvement, which was very limited, was disclosed to participants during the consent process. However, next slide, please. Timing, as I mentioned earlier, this was a study that we were trying to get into the field really soon because of the importance of capturing biomarkers, degradation of environmental samples, minimizing loss to follow-up, recall of information. There was also considerable political and public pressure to do something rapidly to respond to the oil spill. But despite all this, it still took 7 months to get this study into the field. In my opinion, I think some of the things that held it up was probably some of the scientific reviews were probably what held it up more than the IRB reviews. Actually, the IRB tried to work really quickly to get this thing reviewed. In response to this issue, the NIH has developed a special research protocol for rapid response to disasters. I won't go into too much details about what this involves, but basically what the NIH has approved is like a generic protocol for doing this kind of research, disaster-related research. And so all you need to do then is plug in things like the population and the research aims and things like that. And then you can get a pretty quick IRB review for getting this protocol out into the field. Next slide, please. So as far as I know, the Gulf study has not had significant issues related to research design, which I talked about earlier, interpretation of data, or publication of results. Next slide. All right, so this is the Q&A, and I'll stop here and take any questions people have.
Thank you very much for that interesting presentation. I know that there's some discussion that has been going on in the chat, and I'm going to invite people to ask questions. I will just say that even though we didn't quite get to the co-production of knowledge, towards the end of how communities and researchers work together to co-produce knowledge, I think your presentation was really useful in pointing out a lot of the issues that could become ethical issues or just issues in how different community members and researchers view knowledge production or what they're hoping to accomplish with the research. So I think that that's been very helpful in getting us to think through some of those issues. So I'm going to let others ask questions. There is so there is a question in chat and I will read this out to you. So is a community IRB a formalized entity and how does it interact with traditional IRBs?
Well, I think what I meant by community IRB was like a traditional IRB that happens to be within the community. So that's what I meant by it, yeah.
So how do you know how those work? How are they put together by community members and they reviewed the same protocol?
It just depends. It varies. There's so many different kinds of IRBs, right? You might have an IRB from a hospital or a university or even a Native American tribe, a prison. There's lots of institutions that have IRBs and organizations, and they put them together for their own, purposes. So you just have to, in doing this kind of research, you have to identify kind of like who all the IRBs are that are going to be looking at it. But right now, as I said, because of the mandate, the new common rule is sort of doing away with a lot of this. I'm not sure exactly what's going to happen with local representation on these big multi-site studies.
Another question. You noted that a community is often heterogeneous. How would you advise faculty members to select a community advisory board member?
That's a really good question. I guess I would, I've selected IRB members before to serve on the IRB. And what you look for is someone that in some sense represents the community, if that's what you're looking for. So I'll give you an example. In where we are in Durham, North Carolina, there's a significant African-American population in Durham. So I think it's probably like 40 or 50%. And so we used to have an IRB. We would always make an effort to make sure that we had somebody on the IRB that, was an African-American and, lived in the Durham area and was knowledgeable of the need, those interests and concerns, so they could represent them. Another thing that we look for is somebody that was really good at interacting with scientists and understanding the lay perspective on things, but also being able to interact with scientists very well. But there's no real, when you think about these committees, it's not a political process. It's not like anybody's elected to these things. You just get appointed. It's like somebody knows somebody knows somebody, and that's how you get appointed to one of these committees.
So that's specifically for IRBs. Is that something that would you think carry over to advisory boards for community-based participatory research?
Well, I think so. I mean, some of it just depends. I mean, for the Gulf study, for example, there were some identifiable organizations that you could have a representative from, like public health departments and government and hospitals. But then, I think we included somebody from the Vietnamese community and then somebody from the Creole community. But how do you pick those people, right? I'm sorry if I'm not giving you a lot of information here, not helping you that much, but I don't think there's a science to this. I think you just have to use your best judgment to try to pick people who are representative. I know we had church groups on the advisory board, but again, you're not going to be able to pick every church, right? You can't get every denomination on your board, right? So you just have to pick some that you think are representative. I think that's what you're trying to go for is representativeness on the board.
Mm-hmm. I do have a question that kind of ties to something that we were just talking about with community IRBs. So, and granted, you said that community IRBs with the common rule, it's not clear how they will function. But can you speak to interaction of an NIEHS or NIH IRB with some of the information that researchers are getting from community IRBs? I mean, how would you handle that as an institutional IRB if a community IRB is coming and saying, we don't agree with this, or we think that something you need more of this, or something that the researchers are trying to do isn't really applying to the principle of beneficence, or so how would you handle that? What can you share your perspectives on that?
You mean like if there's a disagreement between the IRBs about a study?
Yeah, between the community IRB and your institutional IRB, for example.
Right. I think what we have tended to do is we basically have stuck to our guns. I know a situation we had like this. It's not the Gulf study, but it was in Africa, and we were doing a study. The NIH was sponsoring it, and there were some issues that were brought to our attention about HIV testing. And basically, HIV testing was being done as part of the study because it was study, about how DDT affects pregnancy and blood and things like that. And they just needed information about HIV status. There were strong objections to this. Basically, women wanted to be in the study, but they did not want to be informed about their HIV status because of the stigma and everything else in that country of HIV. I think it was in South Africa where this was being done. And basically we said, the NIH attorneys and everybody else said to us, we can't test people for HIV and not tell them their HIV status. That we just can't do that, right? So basically we stuck to our guns, and then it was actually a solution was negotiated. So basically women that had this concern, we said, on the consent form, I will opt out of HIV testing. So the researchers figured out that they didn't actually need to test everybody for HIV. It wouldn't interfere with the data collection and analysis if they didn't test everybody. So they said, you can opt out of HIV testing. That way we wouldn't be put in a position where we tested somebody for HIV and we weren't telling them their status. But yeah, so I don't really know, because I've worked for the NIH, and the NIH is the big dog, right? They have a lot of money and a lot of power. I think when it comes to these issues, it's going to be the big players that dictate the terms of the research. I just think that's the way it's going to often be, whether it's the NIH or some big operation, other big university like a Johns Hopkins or a Duke or a Harvard or something like that. They're probably going to have the money and the power to have a considerable influence over how the research gets done.
Thank you.
Mhm.
Another question that we have is, can you say a bit more about the conflict of interest and engendered in BP's so-called gift to NIH?
Well, I don't know a lot more than what I said. I think they gave it to a general fund, right? And then the general fund gave it to this study. So it was a conflict of interest, but I mean, it had to be disclosed, obviously. But when you think about it, this is not at all like a pharmaceutical company that's sponsoring a drug study where they would have the power to shape the outcome of the study, right? It seemed to me that BP had almost no ability to affect the study. But the conflict still had to be, disclosed to the subjects.
If there are follow-up on that question, please let us know by typing into the chat. And I will move on with another question. So when a research project involves very technical, highly specialized work, how would co-production work in that aspect of the project? Other than explain the methods and results, how do you convince community partners that a black box of science, when that black box of science is obtuse or impenetrable? I hope I got that right.
I think I understand what the question is about. And that's the problem. I mean, like I said, with CBPR, the community members, they can understand a survey, right? They can understand that a survey question about trauma or abuse or something is not worded well, right? That it's going to upset people or they won't understand it. They can understand that, and they can understand consent forms. But when you're talking about highly technical knowledge like statistical design of a study, I don't even know that, right? I mean, and maybe the investigators don't even know that. The biostatistician really knows that the best. So this is for me is a real issue with co-production of knowledge, is that, I don't know, maybe you have to have people that are working together on a team while recognizing that there are different specialties within that team, right? I'm not sure. Let's see.
So there's a react. Oh, you're seeing that as well.
Okay.
I'll read this out for in case anybody will watch this later. So
Okay.
a comment from Dr. Raja, my reaction to the question is the same way that an engineer would engage a linguist in an interdisciplinary project, I guess, with lots of talking back and forth and sharing perspectives. Are there other questions about the presentation or the discussion? Okay, so I guess we're continuing with this. An example is when artificial intelligence tools were proposed to study the data, but the community partners were averse or afraid of artificial intelligence. So that's a concrete example to talk about.
That is an interesting example. And I mean, it would seem that, the community might have, an understanding of artificial intelligence from all these terrible science fiction movies, right? Where AI is doing these terrible things. But so it'd be up to scientists to explain, exactly what the AI is doing in a way that, the community members can understand it and not be afraid of it and things like that. And this kind of raises the issue of that I've worked on in other situations of public and community engagement in research, right? So that's one of the new buzzwords in research is public engagement and community engagement. And what people used to talk about was public education. But the problem with public education, people realize, is that's a one-way street. It's like you're telling these ignorant people about your science so they can understand it and approve it and accept it and you can get buy-in from them. What public engagement is not that at all. You're obviously there's some informing the public and educating the public, but also actually learning about the public, what their concerns are, what their needs, their interests, what they know, what they want to know, things like that. So that there's this, it's more of a two-way street and a mutual interaction. So maybe that's what has to happen in co-produced knowledge is there's that kind of engagement, between different people.
So Samina says, very good point. I have often wondered if co-production of knowledge is a meeting of inductive and deductive modes of research.
Hold on, let me look at this question.
Yeah.
Yeah, I mean, I don't know, to quite frankly. I don't know a lot about co-produced knowledge, right? So I don't know, but I do think this is a very serious issue that has to be thought through, is the fact that you're going to have people that have expertise and highly technical knowledge, right? And how, if you're all on the same team, how do you communicate, right? Now, I run into this problem without even, I guess I consider myself a scientist, if you will, a researcher, but I run into this problem when I'm trying to talk to my statistician, right? They have very technical statistical knowledge that I don't really understand fully, right? And I've even had some statistics classes, but they go way beyond that. So we have to communicate in such a way that even if I don't understand the details of what they're doing, I understand the overall picture, right, of what they're doing, the overall, and I trust them, right? I trust them that they know what they're doing, right? So maybe that's part of what has to happen when you have co-produced knowledge, is you have to have some kind of basic level of understanding and also trust, right? You're not gonna, the community people are just not gonna know what the scientists know, right? And if they did, they themselves would be scientists, right? So.
And the flip side is that researchers don't often know the university researchers don't know the lived experience of community members and can, through conversations and through that process of trust building, can learn about that so that they, the knowledge that's produced is informed by both sides of the story. And I guess that goes back to the inductive and deductive modes of research that Samina has already mentioned, where you're on the one hand learning from the community, and on the other hand sharing what you know with the community. So yeah, I think that's exactly what you're saying. I will ask a question. Something that I found really interesting in your talk is you had said that CBPR can be used for promoting positive impact of research. And some of the examples that you gave were things that people were receiving from the research process, from the researchers, such as test results. But I'm wondering if you could speak to the community members themselves having the sort of being empowered or having the agency through CBPR to create positive impacts for their communities. Can you talk about the potential for that?
Sure. I mean, I think the breast cancer study that I mentioned earlier, they had a really, really high participation rate. They had very little trouble getting people to participate in follow-up studies and things like that. People were very enthusiastic about that project. And I think what was going on was a sense of empowerment they were getting from participating in breast cancer research. Because here they were, you know, their sister has breast cancer. And so, or their daughter, and there were some daughters and families recruited for it too. But so, you know, you feel incredibly powerless when something like that happens. So to participate in research, I think can be empowering. It's like, you know, you can really feel involved in it, like you're doing something important. So I think that's one thing that could be really a really important benefit, even beyond, you know, what we talked about.
Thank you. Are there other questions from our attendees? All right. So I will close by thanking you again for your time and for your presentation, for the study that you've shared with us and your insights. I think that we can carry a lot of that into our thinking about co-produced knowledge. So there are thanks from our audience, and again, thank you so much for joining us.
You're welcome. And keep me, will you share with me the other seminars that you're doing?
Yes, happy to do that.
I'd like to attend some of those and see what direction things are going.
Yeah, that's great. We'll keep you posted.
All right, thank you.
Thanks to the audience. Thank you for joining us, and we'll see you next time.
Okay, thanks. Bye.
Bye.